All right, I think we're going to go ahead and get started. So welcome, everyone. My name is Benjamin Orr. I am the founder, president, and CEO of the Maryland Center on Economic Policy. For those of us who are maybe less familiar with MDCEP, we are a nonprofit, nonpartisan think tank that believes every Marylander should be able to achieve their full potential through a healthy economy that offers a widely shared and rising standard of living. And we're really excited to host this conversation today to learn more about one particular aspect of health equity. And of course, health equity is vital to the promotion of broad prosperity for everyone. Whether you're on your lunch break or this is part of your day-to-day work, thank you for being a part of this conversation. Please take some time to introduce yourself in the chat. And if you feel comfortable, share what brings you here today. I'd also like to make sure that I thank our sponsor for today's conversation, Kaiser Permanente. Speaking of celebrations and sponsorships, our 10th anniversary is coming up this fall. We are holding an in-person and hybrid event, in-person and online, on September 23rd. At the Reginald F. Lewis Museum. And we are so excited to celebrate all the tremendous partnerships and successes that we've had over the last decade, as well as talk about the important work around whether it's childcare or tax justice or workforce issues over the last decade, and also what we need to work on going forward. That we hope that you'll join our conversation on September 29th at the museum. We do have early bird ticket pricing, which ends today. So I'm sure one of my team will throw the link in the chat for folks who are interested in that. For today, we are going to hold some time at the end of our conversation for questions. And you can submit your questions using the QA chat at any point, and we will go through those and ask, as moderator, I will ask the panelists those questions. And so without further ado, let's jump right into this conversation. I'm really excited to have two tremendous guests to share their insights with us today. Bernita Haynes and Marceline White. Excuse me. I'm going to ask Bernita and Marceline to introduce themselves and share more about their commitment to equity and economic justice. And maybe Bernita, we'll start with you.
Hi, thanks for having me here, Ben. And thanks for everyone who's joined. It's wonderful to be able to chat with you about this topic that just really seems to be the gift that keeps on giving. But I am Bernita Haynes. I'm a senior attorney at National Consumer Law Center. For those who are not familiar, we are a national nonprofit law firm that has worked on consumer justice and economic security for low-income and other disadvantaged people for well before I was born, since 1969. And we work on an array of areas, including medical debt, but also power bills, student debt, housing, and so forth. And I'll turn it to Marceline.
Great. Thanks so much. Thanks, Ben. Thanks, Bernita. Happy to be here and be part of this important conversation. I'm Marceline White. I'm the Executive Director of Economic Action Maryland, the organization formerly known as the Maryland Consumer Rights Coalition. And we've been around since 2000. We work on economic rights and equity with a focus including housing justice and direct service. We do research, we do education, we do organizing, and we do policy work at the local, state, and federal level. And happy to be here as part of this important conversation.
Great. So Marceline, maybe you can help us kick off this conversation by really helping us understand medical debt. Can you talk both about the economic and health impacts of medical debt on Marylanders and what makes medical debt different from other types of debt?
Sure, I'm happy to kick it off. I do have a couple slides. So, I think I just wanted to make, that's me, and that's how you can get in touch with us. We have a section on medical debt on our website. So if you can get the next slide. I just wanted to make a couple important points that all hospitals in Maryland are nonprofit hospitals. And as such, that means by law, they must provide free or reduced cost care to patients who are eligible because of where they fall in terms of their poverty, in terms of their percentage of where they are on the federal poverty guidelines. It's also important to know that in Maryland, we have what's called a global budgeting method. And what that means is that the hospitals are prepaid for the charity care that they provide. They're prepaid every year for this reduced cost and free care based on some complicated calculations done by our state oversight body. So I just wanted to kind of lay the table there. Every hospital is a nonprofit. They have to provide this care in order to maintain their tax exempt status, and they are prepaid in Maryland to do so. It's expensive to go to the hospital. As you can see, the average cost is $14,200 for a 4-day stay, and it's a big percentage of healthcare cost in Maryland. If you can get the next slide. I just wanted to call out a couple things from a statewide poll we did in October 2020. Which was the 12% of participants had medical debt they could not pay. And that's actually lower than some national studies have tracked it. So this is not everybody, but this is based on the survey participants who responded to our poll. Of those, 26% could not pay an unexpected $500 bill out of pocket. And what happens is people delay care. We saw this particularly during the COVID pandemic. People did not go to the hospital to seek treatment because they were afraid they already had a medical debt, they already had a medical bill. And I think it's important to note, as you said, this is, this kind of debt, it's not something that you can shop around. You can't be looking at hospital rates while you're in, an ambulance on the way to get your treat your appendix. You can't shop around. Even if you could, it's very hard to compare. And there's a whole set of different prices based on where you fall. If it's a charge master price, if you get free and reduced cost care, if you have insurance. So it's not like other debt, and it does have a disproportionate impact on, if you have medical debt, your access to credit in some cases. And it, from our research, shows that it falls hardest on low-income communities and often on communities of color who are particularly affected because of social determinants of health.
So much of our history as a country, and when we look at issues, we see the impacts of race and gender, but particularly race, on these important issues. And Bernita, last year you wrote about how medical debt affects both the health and economic security of Black families. So maybe you can help us tease this out a little bit more. Medical debt can happen to anyone, of course, but it disproportionately impacts, as Marceline said, low-income communities and communities of color. So can you speak more about the intersection between racial health and wealth gaps, and why does medical debt impact so many families of color?
Yeah, happy to talk a bit more about the racial impacts of medical debt. As Ben said, last year I put out a report called The Racial Health and Wealth Gap. You can find it easily on our website at nclc.org. But that report looked at the impact of medical debt on Black families in particular. And I use those terms, racial health and wealth gap, very specifically here because those two gaps intersect to create this sort of perfect storm of debt, of medical debt for Black families. But I think it's important to first sort of explain what I mean by a racial health gap and racial wealth gap. So the racial wealth gap, which folks are familiar with, I'm sure, really refers to those disparities in income, assets, including home savings, investments, and debts of households across race. As we know, Black folks tend to be more in the racial wealth gap than other demographics. The average wealth of a Black family is much less, for instance, than other groups. The racial health gap, on the other hand, refers to those disparities in healthcare access and healthcare quality and health outcomes of households across race. So you may wonder how these two things connected, how do they impact to create this sort of, interact to create this sort of disparate impact of medical debt we see on Black families? Well, the racial health gap looks like chronic conditions and health risks like cancer and infant and maternal mortality, heart disease, all disparately affecting Black families, and the fact that Black individuals have higher rates of being uninsured. The racial wealth gap in reality looks like the fact that in 2020, for instance, the Federal Reserve reported that the median net worth of Black families was 24,100 compared to 188,200 for white families. That's not a number that a comparison of numbers that has changed very much. That stays pretty steady. So what does it mean then? Well, it means that because Black folks are more likely to experience chronic conditions, more likely to be uninsured, they are more likely to incur medical debt. Folks with chronic conditions interact with the healthcare system more than folks without chronic conditions. The more you interface with the health system, the more likely you are to deal with medical bills and debt. Lack of insurance is one of the leading reasons for medical debt, one of the leading causes of medical debt. Lack of wealth means that when those bills arrive, as they inevitably will arrive, Black families, because there's a lack of wealth there, are less able to weather those financial hardships when they arrive. They don't have a family member necessarily that they can turn to for a couple $1,000s to pay a medical bill. They don't have investments necessarily to tap into to weather those financial storms. So yes, medical debt disparately impacts Black families significantly. It is very important to note that Black folks are more concentrated in the South as a population. This is also the region, I'm located in the South, Atlanta. This is also the region that has by far not expanded Medicaid. And so we have a higher rate of uninsured people in this region, many of whom are Black, because Medicaid was never expanded. Georgia, I think for the past several years, has had the 4th highest uninsured rate in the country, for instance. So residing in this region puts us at greater impact, risk, I should say, for medical debt compared to other groups. And I'll end off with just a couple of stats that I think are really important to keep in mind. 1 in 3 Black adults have past due medical bills compared to 1 in 4 white adults. 17% of Black adults lack health insurance compared to 12% of white adults. That's national. Once you nutshell that to the South, those numbers may look even more stark. So I'll stop there because there's a lot more that I can say, but I want to give us time to continue on into what some of the solutions are, so we're not just talking about what the problems are.
Absolutely, absolutely. And even though Maryland is thankfully not one of those states that didn't expand Medicaid, we still have folks falling through the cracks. We still have folks who lack health insurance, and the wealth gap is still real, and the health outcomes gap is still real. Absolutely. Marceline, Bernita did a great job of kind of walking us through an example or two of how folks can fall into medical debt when they don't have a lot of resources, or it can be exacerbated by public policy decisions. And so can you talk a little bit about what we can do to protect consumers, especially people of color, and increase patient confidence so that people actually feel free to access the needed healthcare that they have available to them? I also think this is often a very fast-moving field. So in addition to things that we need to do going forward, are there any recent law changes that Marylanders should be mindful of?
Sure, I'm happy to talk about this, and I appreciate Bernita's comments. I think it's an interesting conversation because obviously Maryland would be seen as one of the states that's doing the most. Unlike the South, we have this global budgeting. We have done a lot of work in terms of expanding healthcare, and yet we still see, despite that effort, thousands and thousands of people falling through the cracks for a variety of reasons. And again, disproportionately affecting Black and brown communities. So it creates this kind of perfect cycle where, I have a friend who's a nurse practitioner who says she'll treat somebody for cardiac issues. They are in great shape. They leave the hospital, they get a medical bill, their blood pressure goes up, they're sick again. And so it's creating this vicious cycle of illness because the system is diseased, not the individuals necessarily. But let me just talk a little bit. We try to look at it on two across the whole spectrum of medical debt. So the financial assistance policies and then the debt collection policies. And if I'll just pull up a slide and I can talk a little bit about both of those and then what we've done. So in terms of financial assistance, again, by law, Maryland needs to cover financial assistance for everyone. But in our survey, again, this talks about the disparate impact. 29% of people surveyed had no knowledge at all that hospitals had to provide financial assistance. And this is despite laws saying that they have to post it and make a note of it to people. And this is from 2020. And of those, 50% of African-American respondents had no idea the financial assistance was available. So they are not doing a good job promoting the financial assistance. The other things we see with financial assistance is that in many cases, despite the fact that there's supposed to be a uniform application people can use, it's been very burdensome for people to apply for financial assistance. You often have to document your, income, use your tax forms from the year before. You often have to fill out information about your sources of income, your debt, all of which can be really burdensome and complicated for individuals, particularly when they're recovering from cancer or a stroke or something else. They're supposed to fill out these pages and pages of forms in order to receive financial assistance. So many people don't. And in fact, until recently, some of the hospitals had notices on the financial assistance forms saying that you had to have proof of citizenship or proof of residency status. So again, for a lot of Marylanders, that simply was a deterrent and they weren't able to proceed and complete their applications. There was a real chilling effect for some of our community. And even when you go through that whole process, some of the hospitals we've seen deny the applications 50% of the time. So you go through that entire process and these hospitals, they're just supposed to provide charity care, have a 50% rejection rate. And it's not clear why, because there's just not the transparency we need. So you can see charity care fell by 36% over a 9-year period. And the other piece on this is that they do a poor job screening who may qualify. A study that was prompted from legislation we passed showed that 60% of the patients that should have received free care were written off as bad debt and pursued for debt collection. So of those, 1% repaid the hospital $60 million in 2017 and $60 million in 2018. So again, the application process is difficult. And even afterwards, they're writing people off for bad debt that should have gotten free care. And then they're suing people. So if we can just go to the next slide, I'll just go over this quickly. We did research and we looked at medical debt lawsuits on the other end of the spectrum, which is that, again, over a 9-year period, there were 145,000, more than 145,000 lawsuits filed for patients who'd sought medical care at a hospital. And you can see, more than 37,000 wage garnishments, property liens, bankruptcies, all because of hospital medical debt. And the average amount was $945 that these hospitals were suing for. Again, we found they were mainly taking place in low-income communities, in communities of color, and often people who worked at the hospitals were being sued and seeing their wages garnished, which is when they found out they had a debt in collection. If they were a nurse, nursing staff, assistant, janitorial staff, food service worker, we're seeing people that were working in the hospitals finding their wages frozen, wages garnished, bank accounts frozen. So there's a lot to do. We've done a lot of work. We did pass legislation, if you just go to the next slide, increasing the threshold for financial assistance to 200% and creating a payment plan for low income and working families to have some kind of payment plan that's not onerous or usurious. We also removed the question about citizenship status. In 2021, the End Medical Debt Coalition was created, which which MDCEP is part of as well. And that coalition worked to pass the Medical Debt Protection Act, which does a number of things in terms of reporting and expanding timelines, delaying when things can be reported to credit reporting agencies, and establishes an installment payment plan, as well as bans liens on primary homes and wage garnishment for those who got free care. And then in the past couple of years, we've been focused on trying to make patients whole. I told you that number about people that were pursued for debt collection when they should have gotten free care. The past few years have been focused on legislation that would identify, notify, and require hospitals to pay those patients back. So that's what we have been doing. And I know there's a lot of work happening at the federal level and more that we're going to be working on in 2024.
Thank you, Marceline. And just to give folks context, I mean, when we're talking about you qualify for free care up to 200% of the federal poverty line, we're talking about the federal poverty line for a family of four is $30,000 this year. So $60,000 or less, you ought to be able to be receiving free care, and above that, up to $150,000, we're talking the hospital should be working with you to negotiate a payment plan. I think is how I understood that slide.
Yeah, 200 to 500% of the federal poverty line, you could reduce cost care.
Right. So if you have a family of four, that puts that 500% puts you at $150,000. So I want to turn back to you, Netta, and I'm getting back to my notes. Pardon me. The health inequities exacerbated by medical debt clearly make this a racial justice issue. So could you talk a little bit more about the ways we can change our current health system and make it so it works for everyone, and what that would mean, what that would take?
Absolutely. And I do want to, before I even jump into that, add on to something that Marceline mentioned, that focus that you had on all these, lawsuits that folks are facing, resulting in wage garnishment and all these kinds of things. I want to make sure that it is clear that all of that is happening as hospital revenues are increasing. Okay. And Maryland Nurses United put out this great report some years ago where they specifically said, showed that as spending on charity care decreased, revenues increased at Maryland nonprofit hospitals that have filed, somewhere around the range of 145,000 or more medical debt lawsuits over a period of years, totaling $268 million. All of this is happening. Hospitals are spending less on charity care as hospital revenues are going up. So it is very important for us, I think, to recognize the fundamental issue here, which is that why? The question should be, why are hospitals pursuing individuals for such small amounts of money when their hospital revenues are ballooning in ways that we haven't seen ever before? So I just want to make sure that I mention that, because I think that's an important question beyond what I'm going to talk about in terms of solutions. Now, in terms of solutions, I do want to go back to this issue around charity care, because one of the solutions is to significantly improve charity care, and some of the ways that Marceline has already pointed out. But let me be very clear about how and why charity care fails so often. So charity care is required under the ACA. All right, for all nonprofit hospitals, they have to provide some financial assistance. Now, the problem here is that patients, as Marceline noted, are not informed of their eligibility before the hospital starts debt collection. The ACA provides no specific guidelines and minimum eligibility criteria in its financial assistance policy. That means hospital by hospital or state by state, in some cases, you may see different income eligibility thresholds. And then there's just an overall lack of enforcement. The IRS is the enforcement hand of the ACA and of this particular charity care provision, and they have been pretty much inactive on this front. Some of that due to lack of funding, some of it just due to reasons we can't really make sense of. So the failure of charity care happens for a few reasons. And it really requires, number one, in terms of solutions, an improvement to the ACA. at the federal level. Some sort of expansion of the ACA requirements to include nonprofit hospital, ambulatory surgical centers, all nonprofit outpatient clinics, but to also broaden the income eligibility requirements and lay out specific income thresholds as a floor. Improving the ACA's charity care requirements to cover uninsured and insured people alike is extremely important. Requiring screening of patients up front for financial assistance. Currently, Connecticut and I think one other state requires screening for financial assistance up front. But this is extremely important, and it would weed out some of those problems that Marceline mentioned in Maryland about folks just not knowing that financial assistance is available. Maryland, however, has taken a great step in terms of requiring hospitals to reimburse patients that would have been eligible. But some other solutions for medical debt and relieving this burden for folks also include tackling medical debt after the fact. So financial assistance is really kind of about preventing it before it even happens. But what happens when people have medical debt? They're dealing with potential wage garnishment, all kinds of predatory debt collection, prohibiting aggressive debt collection at the federal level would be a fantastic starting point to relieve some of the stress from folks. I'm talking prohibiting wage garnishment, liens on homes, seizure of bank accounts, civil arrest warrants, or body attachments. And I'll end off because there's a lot more that I can say, like removing medical debts from credit reports. Incredibly important. But canceling medical debt outright for those who are dealing with medical debt currently is invaluable, but that cannot solve the problem without some sort of set of policies that improve financial assistance, that removes medical debt from credit reports, and also, very importantly, considering a way to ensure that everyone is actually insured. That may be going beyond what Maryland has already done, which is Medicaid expansion, but looking at some more universal kind of policy that would make sure everyone's insured. Because as I said, lack of insurance is one of the key risk factors for incurring medical debt. So I'll stop there, but suffice to say there are a multitude of solutions around how to reduce this problem for Black families in particular, but for everyone. And that really does involve improving charity care, prohibiting crazy kinds of debt collection activities, canceling medical debt outright, removing it from credit reports, and considering a universal policy of some sort to make sure everyone's covered.
Thank you. I think that we've had such an insightful discussion so far, and we're heading into the audience Q&A portion of our webinar. As a reminder, you can submit your questions using the Q&A feature at the bottom of your Zoom screen. While we give everyone a chance to gather their thoughts, Marceline, are there ongoing advocacy efforts around changing the state's policies on medical debt, and how can people get involved?
It's a great question, Ben. There are, as I mentioned, End Medical Debt Maryland is a coalition of more than 160 organizations. I know we're both part of it, that have united to try to address basically medical debt in the state, and banded together to pass a lot of the legislation that I talked about before. We are looking at new legislation going into the 2024 session. We're still figuring out exactly what it will be, but likely will focus around financial assistance policies. In Maryland, as Bernita said, some of the requirements depend hospital by hospital. So if I broke my leg in Montgomery County, I could have a very different experience in terms of what is covered and what the application process looks like and their collection activities than I would if I broke it in Baltimore City, and that makes no sense. It's very capricious. And so one of the things that we're talking about is that some hospitals require an asset test, which means even though you meet the criteria under where you fall under the federal poverty guidelines, you may have saved up money for retirement, or you may have been gifted a house from your grandmother. And that could mean, according to these hospitals, that even though you meet the income limits, you would still be pursued for medical debt collection, which makes no sense. Again, we know a lot of people who their only wealth is their house. And so we want to really address that issue, as well as some hospitals have service areas. So they'll only provide the charity care for people who live within their kind of zip code. And if I broke my leg in Montgomery County because I live in Baltimore City, maybe they wouldn't cover me, even though I'm not going to go an hour away, when I'm having an emergency. So again, looking at some of these policies that make no sense. And I agree with Bernita. There needs to be tons more around what the IRS can do, but at the local level, at the state level, looking more at community benefits and trying to get more information and looking at the charity care, creating more opportunities for real engagement from community members around what charity care really looks like and what these community benefits really look like is one thing that we're also looking at. Some other states have done a very good job, and others have also just completely banned garnishments entirely. So looking at strengthening as well. I know, Bernita, I don't know if you had more thoughts about the assets.
Yeah, I'm so glad you brought up the income and assets issue, because it does illustrate that in terms of determinations for who's qualified, in terms of understanding people's financial well-being, it takes more than just looking at one factor, right? I think that is really important for Black families in particular. This is something we've had conversations about at NCLC. For folks like me, for instance, who are first generation college students in my family, income may not be enough to actually determine one's ability to, my ability to actually weather some of these medical bills, because it doesn't necessarily take into account my debt ratio, right? So if my income is, as a first generation lawyer in the family, is 90 or 100, what does that mean though if my student debt is 90 or 100? What does that mean if if I have like a substantial debt like that related to education? I also want to emphasize that, because not is it just important because of the debt that one may have, but a lot of Black families, and this is actually true for many families of color, where folks are the first generation, whatever in their family, they're providing a lot of money to other family members. So even if their income is substantial, they're often helping mom pay her bills or this or that family member. So all that to say, I think across the board, not just in Maryland, but across the board, we need to be trying to figure out how to take a better survey of people's financial well-being to determine their qualifications for some of these benefits, in this case, financial assistance.
So I think we have a question from the audience that's kind of related to this. And so the question is particularly concerned with the elderly and what happens. And the question is, what happens if they're at the hospital or at nursing homes and they run out of money? How will Medicaid or Medicare help? And what's the sort of immediacy of that financial assistance? And what's the, is, I guess to add on to the question, does medical debt look differently for our older residents as compared to other Marylanders?
I can start by talking about how it affects older adults. We've had a program called the Medical Debt Freedom Fund, which is really designed to help, be liberatory in terms of helping people pay off small medical debts. And the largest number of people who've applied to the fund are older adults who, after we've gone through their application assistance, we found they should have all gotten free care, but they didn't. They were, again, these folks who fell through the cracks. And we're talking about, for some of the folks we've helped, it's a $100 medical bill, but when you're living on a fixed income, that's a huge proportion of your income. So we see so many older adults who an unexpected medical bill or prescriptions that aren't covered can be devastating for their very careful, very modest, and very planned budget. And in fact, some of the survey work we've done internally with our older adult population that we work with through our SOAR program, the third biggest expense that's destabilizing for most of these elders is medical debt. So I think we have to do a lot more work in terms of outreach. Again, as Bernita was saying, I think hospitals should be screening everyone before they leave the hospital to see if they qualify for financial assistance and getting them enrolled right away, but also more wraparound services for our elders and more financial navigators to help them. Because again, a lot of these applications, you can print them out, but a lot of them are fillable online. So again, there's lots of issues in terms of digital equity in Baltimore and in rural Maryland that people can't always get in line online and have a stable connection to be able to fill out the applications. With the nursing homes, maybe Bernita can talk a little bit more about it, but they're not nonprofit. And so there are different policies and procedures. They're not required to be nonprofits. And in fact, one of the things we see is a lot of private equity who are buying into nursing homes, which causes a whole different set of issues.
Yeah, this is exactly why I mentioned that one point in the solutions discussion about the importance of broadening the ACA's charity care provisions to include nonprofit and for-profits and a variety of different nonprofit types of facilities, because nursing homes are not often included in that. It's also important to note too that nursing home debt often can fall on near family members who may sign agreements with the nursing home, inadvertently assuming responsibility for the debt. So the kind of ripple effects that nursing home debt can have are a bit different than typical medical debt and much broader in their impact. And as Marceline also mentioned, we're talking older folks who are on fixed incomes. Folks who are on fixed incomes have much less ability to deal with sudden medical bills and so forth.
Is it even possible to avoid medical debt with our current set of options?
It's hard to say. I would say no. I think anyone, and I think that's why this issue has become so important and so widely covered, because I think medical debt has the potential to affect everybody, whether you're insured, uninsured, poor, not poor, Black, white, whatever. So it's very difficult to avoid medical bills, if not impossible. It would be my answer.
Yeah, I would agree. I mean, I think the unfortunate fact of our healthcare system is if you go to the hospital, even if you have insurance, you may have a high deductible, or you have things that are not covered. So I think it's very hard to avoid it. I think, we're trying to address it by expanding who's covered by financial assistance and then creating these payment plans, which are not completed, but the idea of the payment plans that were in the 2021 Medical Debt Protection Act was that anyone, if you have $100,000, you can still get on a payment plan. If you have $200,000, you can still get on a payment plan, and it's no more than 5% of your gross monthly wage. That actual plan is still being worked out through Maryland regulations. But I think that will also help people because, as Bernita said, a lot of people look really good on paper in terms of their income, but that doesn't account for their debt to income ratio. And when people talked about payday lending, which is banned, of course, in Maryland, but one of the things people talked about is looking at debt to income ratio. And I think we should be doing that across the board because, someone who has $100,000 in a trust fund may look very different than someone who makes $100,000 but has a $90,000 in law school debt. And you need to be able to be more granular or more nuanced about what people's real situations are in terms of making those kinds of determinations.
Marceline, you earlier talked about the differences across counties in Maryland, and I know a lot of conversation has happened lately around the differences between access to healthcare across state lines. That's not necessarily the focus of this particular webinar, but I am curious if how differences in state law across state lines, and also, Maryland is a small state, and some places the nearest hospital may be in another state. What's the intersection there between variation in state laws and medical debt? Or is there one? And if there is, what is it?
Yeah, it's a great question. In fact, I think it was this weekend or a few days ago, there was some news that Johns Hopkins was opening in Pennsylvania. They were opening a hospital as part of their chain. And I think, it'll be interesting to see what they're using in terms of which laws govern them in Pennsylvania. But when we've talked to folks in rural Maryland, one of the things they've said is that it's easier for them sometimes to go to West Virginia or to go to Pennsylvania for treatment because of where they live than it is to stay in Maryland, because access is such an issue and a lot of the rural hospitals have closed. And what that means is that we've worked to put in place some protections in Maryland. We still have a lot of work to do, but we've done our best. But if you're going to a hospital in West Virginia or Pennsylvania, you're not going to be availing yourself of those protections. And again, I think it's why the national issues and the national solutions Bernita was talking about are so important. I know Senator Van Hollen has introduced legislation around medical debt collection for several years now, which would address some of the most onerous requirements. But that's why, in addition to whatever's happening at the state level, looking at surrounding states is really important, because you lose those protections once you cross state lines.
Yeah, just to add to that, we've had, the introduction of some interesting legislation at the federal level over the past couple of years, especially spurred by COVID. But, no movement on them, no passage of this legislation. So, the COVID-19 Medical Debt Relief Act, I believe it was SB 355. It was introduced, but it wasn't passed. It would have prevented a lot of these extraordinary collection actions. Right. And then the Medical Debt Relief Act was a couple of companion bills, one introduced by Waters and another by To Live in 2021, would have removed medical debts from credit reports for a variety of within a few parameters. Basically, what we've seen credit bureaus voluntarily do, that bill would have made law. But there's just not been any, real movement since the No Surprises Act was passed in 2020. And the No Surprises Act is important. It will hopefully go a long way, as time will tell, to reducing some of the worst kinds of medical deaths, those surprise ones that often happen in emergency room visits. But it's not enough. It's not enough. And it's why, no matter how many times I have these conversations, I constantly emphasize the importance and the value of talking about whether we really believe folks have a right to healthcare. Because if our answer to that is yes, then there are some things that we simply should not allow in this country, whether it's Maryland or outside of Maryland. And one of them is medical debt.
Yep.
Yeah, it's just obvious. Financial assistance should be available. If we're not going to have a universal system, we should have robust financial assistance policies that really do help a lot of people, not just, the poorest, not just those who have the wherewithal to read in English the applications, and so forth.
Yeah, no, I agree. And I think at least in Maryland, that's why some of these bills have had bipartisan support, because, again, no one should be losing your home, have your bank account zeroed out, be arrested and jailed, have all of your wages garnished to the point where you're below the poverty line because you got sick. I mean, again, I think you look at other countries and you try to explain it to them and they're just, gobsmacked, frankly. It's hard for them to fathom this. And I agree with the need for some sort of universal system, but until we get to that point, we have to do all of these other pieces. But I think certainly that's where we need to be moving, and that's where we need to be going, because you don't have people losing their homes in other countries because they got ill, and trying to explain it. Again, people have such a hard time understanding it in other parts of the world.
Yeah.
How would somebody know if medical debt is affecting their credit score? We talked about sometimes you don't even know you have the debt until you end up with your wages garnished, for example. So how do you find, even not just your credit score, but just how might you find out if you have medical debt if you haven't seen a letter or you accidentally threw it away or whatever? Are there ways to figure this out?
Yeah, this is why it's important to pull your credit report frequently. At the federal level, you're allowed to pull your credit report at annualcreditreport.com for free. super essential to pull your credit report there just to make sure that things that you are not aware of aren't showing up on your credit report. Because otherwise, you're not going to know until you go to get a loan for a car and they say, wait, your credit score has dropped to, this, that, or the other. You're not going to know. That said, the changes that the three major credit bureaus have implemented recently should go a long way towards helping reduce the impacts of medical debt on credit reports, such as not putting medical debts on credit reports until a year has passed. For instance, removing any any paid medical debts from credit reports, and then medical bills that are under $500 not showing up on credit reports. So some of those changes should help folks, but it's still going to leave a lot of people open to credit score and credit report impacts from medical debts.
And I would just add, as I was talking about earlier, the hospital system themselves have not done a good job of tracking and distinguishing who has bad debt and who should have gotten financial assistance. And so we've seen lawsuits where they have, had someone with the same name or similar name that they've sued for medical debt and it was the wrong person. And in fact, certain hospitals, even when the person has proved that they're the wrong person, they've not changed the debt collection. Because they've already gotten it approved by the courts. And so even if the person can prove they're the wrong person, this person won a judgment. But we've seen a lot of those cases, people have similar names or identical names, but different person. The hospitals have pursued the wrong person. And so that's affecting your credit, that's affecting, lots of things. So again, the onus should not be on individuals, and it certainly shouldn't be on sick patients who are recovering. But I do think you want to look at those carefully. And there are self-help centers in Maryland that can talk to you about medical debt. There are lawyers who are pro bono who can work with you a little bit and help you look at these things. There are national organizations like $4 who can help you with financial assistance to see if you screen, can help you apply. So there are sources of help that are springing up to address this issue. So the other thing is just if you get a medical bill and you feel overwhelmed, there is help available in the state and at the national level. So take a breath, and start looking for some resources and, because they are out there, including our Attorney General's office.
And there are certified credit counselors as well. I think you can go to maybe the FTC website to find a list of certified credit counselors that can definitely give you a sense of what your credit situation is and whether, what they suggest as well.
We have a late entry in our questions. Let me see here. So if hospitals in Maryland are spending less than they receive on charity care, are they returning the difference to the state or to some other nonprofit organization who can provide financial assistance? What happens to that money?
That is an excellent question. The short answer is no, they are not returning the money. This year, because of legislation that passed, there will be greater reporting on the community benefits that hospitals have to provide as part of their nonprofit status. What we would expect to see is because they are already paid for charity care, that their charity care lines will be very small because that's already covered. So that shouldn't be part of their community benefits because it's already covered in another place. But, I would not be surprised if we still saw robust reporting of charity care in their community benefits. Right now, that's part of the issue advocates have been saying is that the care is declining. As Bernita said, profits have gone up, executive compensation has gone up, charity care has gone down. So the system is not working. And again, in a place like Maryland that is, proud of itself, this is terrible. So you can only imagine what's happening in other states that don't have even the kind of reporting and robust protections we have, where we have a lot more work to do. I know that the situation's even more difficult in other places, But that's the actual problem, is that the charity care, we don't know. There is a state oversight body, and
Mhm.
talking to them and trying to work through regulations around that. But they have, there's a lot more that could happen on the enforcement side, both from the Attorney General's office as well as the state oversight bodies. And that's something that we're certainly having conversations about as well.
Yeah, I'll just add that from a general standpoint, it's almost impossible currently to hold hospitals accountable for their lack of compliance with financial assistance requirements, specifically under the ACA. Basically, as long as hospitals engage in some charity care and report it to the IRS, they usually can retain their nonprofit tax exempt status. Individuals have no private right to sue a hospital for non-compliance. Or anything like that. This is really a situation where we need much stronger regulations and some sort of push for greater enforcement of those regulations. NCLC has had conversations with the Consumer Financial Protection Bureau to encourage them to work with the IRS to issue some sort of guidance around financial assistance to hospitals, just to make sure that hospitals are fully aware of what they should be doing. Those conversations are ongoing, but that would be, one starting point to maybe increase enforcement. Because without enforcement, we're in a situation where it's like, the individual who asked that question, there's this money that they're receiving and they're not spending it on charity care, and they're not suffering any consequences as a result. So.
And I would just agree, just building on that. I think, if Maryland hospitals want to act as for-profits, great, they can do that, but then they don't get the benefits of the nonprofit tax status, and they need to return those monies to Maryland, to Baltimore City, to rural Maryland. All of that money that they're saving right now needs to be returned to the community if they're not going to act like nonprofits.
Right.
Well, I want to really thank both of you. This has been a tremendously important conversation. It's an issue that affects everyone, and even those, folks who think they might be protected from medical debt. One random expense or sudden diagnosis can change that in a heartbeat, or maybe you just have the wrong name, as Marceline said. So I really appreciate this. This has been a great conversation. We will make sure to share out the resources that were mentioned on this webinar, and any links that were shared will go out. But I also want to highlight that this is not the end of this conversation. Marceline highlighted a number of actions that advocates and interested folks can take in the next year here in Maryland, and we also will be continuing this series on equity issues within the health space. So keep an eye out for future webinars from the Maryland Center on Economic Policy, and also we hope to see many of you at our 10th anniversary celebration in September at the Reginald F. Lewis Museum of African American History and Culture in Maryland. So with that, thank you again to our two panelists, and we will say everybody stay healthy and enjoy the rest of your week. Thank you.
Thank you.
Bye, y'all.
Thank you. Bye.